Ladies and gentlemen, once again, it is a pleasure for me to stay with you all and to have the possibility to speak in front of you and logically to share all the my materials. I want to thank again Dr. Ho and Mr. Lee and logical Dr. Hayon for having invited me and to stay with me in this time. I re-underline that I'm here not to teach anything to you, but I just want to share with you all my knowledge. And today it will be the second part of, it doesn't start, the second part of my presentation when it wants to start. Why it doesn't work? Okay, this is the second part of my presentation, and I want to start with a little summary. Last week, we talked about the importance of how to plan accurately a case, about the advantages or disadvantages of an immediate loading protocol, and we talk about the soft and the hard tissue characteristics, and about how to position an implant. Today, I have trouble. Oh. Today, we continue with this speech, and we start the new part with a little motto. Motto is a way to say, and is overboost the site. Every time I work in the front area, I like to overboost the site because the results will be better. And what I do, I place a connective tissue graft without elevating a flap with a tunnel technique like what you see into the picture. And doing this with autologous connective tissue graft, I have some advantages. And the most important are that I increase the resistance to the recession and I decrease the tissue transparency. So it is easy to camouflage the gray components that stay under the tissue in this way. Furthermore, to place a connective tissue graft stimulates keratinization of the underlying mucosa, and how you can see from the slide is an old matter. Already in 1975, we know about this. So every time I stay in the front area, or almost the time I stay in this area, I do this. At this time, a question arises immediately. Is the treatment stable over time? Because everything we do with Ulai remains stable. And the answer is yes. Yes, if the implant is well positioned and some bond grafting material is placed into the implant socket gap, so between the implant and the buccal bone. And placing this bone and placing the connective tissue, and logically inserting the implant in the correct way in the 3D in the space, the result over time. Chu and Arnold years ago said that it was better to place the bone not at the crest, but at the gingival margin, like you can see with my laser. Since that time, in 2012, if I don't mistake, I placed the bone at this level, and I have increased the result of my work. The work is better, and the results are more stable and gay. So, connective tissue graft and bone up to the gingival margin. And this is what I do. With an elevator, I detach the gingiva from the bone, and with the suspended suture, I make the connective tissue graft come inside the tunnel, and then I stabilize it with a simple suture. So just two simple suture, and the work is finished. It takes very, very slow, very, very low time, and the result is absolutely better. And you can see these are the results at 10 years. And from the left side to the right side of the image, you can see that the tissue are very stable, and it's almost impossible to say that there is an implant for this tooth. But patients not always like to undergo a tissue harvesting from the palate. Nowadays, in the USA, there is a new motto, and the motto is save the palate. It's a terrible motto, in my opinion. Probably is a motto from the commercial factory. Is advertising. But this is the trend. So there is a lot of people that doesn't say, no, doctor, I don't want that you take my palate to change the position to the connective tissue graft. I don't like this. I don't want a second side for the surgery. So we can use something else. And something else is a dermal matrix. There are many kinds of dermal matrix on trade, and we can choose what we like. But absolutely, they are less effective. The autologous connective tissue works better, but is always better than nothing. How you can see in this picture, this is a dermal matrix. This is the bone into the gap between the implant and the buccal bone side. This is the matrix, and the tissue are a little bit pushed away, like a bump. This is the result at 6 months in the left side, and at 1 year with the definitive restoration in the right side. The results are almost alike. It's possible to see a little minus in this area, but this is a nice result. Not always the results are like this. So you have a nice parabola, nice papilla, is almost similar to the beginning, but is not as nice as the connective tissue graft. So the first choice for me is always the connective tissue graft. Many years ago, Giuliano Garlini and me made a research. We took 5 patients treated with immediate post-extractive implant and immediate provisionalization, and we made them some digital impression before and at 1 year from the surgery. And then we superimposed this file to see how the thickness of the tissue changes during the time. We take 6 different positions to mark, and these are the results. How you can see, the results is always minus, minus, minus apart 2 sides. So I want to say that using a dermal matrix, the connective tissue around the teeth doesn't remain stable, and it diminishes almost always is thickness. The dermal matrix absolutely works, but less than the connective tissue graft. So they have a little shrinkage, and the matrix is not able to counteract completely this shrinkage. So it's a second choice, it's not our favorite choice. And this is me and Giuliano during a presentation of a matrix that you can find on trade now. Many, many years ago, I believe in Madrid. Anyway, another question that we can make is keratinized mucosa is indispensable or not. We are speaking about philosophy probably, because in the literature you can find that it is indispensable and that it is not. So what is the reality? The reality is that if the patient is able to clean very well and the plaque is controlled in a very well manner, it is not indispensable. But in normal patient, it's better to have it, because keratinized mucosa give more resistance during chewing, and the tissue are more trophic and are more nice to see, to view. Anyway, Giuliano and me say that keratinized tissue is like the money. If there is, it is absolutely better. It facilitates maintenance of the oral hygiene. It better covers the gray color of the metal components and improve prosthesis emergence profile. So every time we can, we overboost the site and we place a connective tissue graft. If the patient doesn't want to harvest the connective tissue from his palate, then we use a dermal matrix. But in the aesthetic area, we always and always do this. And we like keratinized mucosa a lot. Another question that will arise, and what is better to do between GBR or CTG? What is better? In the literature, you can find also in this, for this matter, two philosophic trends. It's better GBR or it's better CTG? I believe that both have the same importance. And many of the time I do both GBR and both CTG. I like both. On the other hand, if I don't manage everything like I've shown you now, what's happened? This is the result. A little minus. Do you see? There is a concavity, a slightly buccal plate shrinkage. In the posterior area, nothing matters. In the front area, this is a tragedy, in my opinion. A dark shade can appear. Logically, on this tooth, you never see the dark shade, but in the frontal area, this dark shade, it would be very, very, very bad. And I believe it's horrible. But there is another problem. Here, I don't see this minus. I don't see this gray shade. But in this area, the food can be trapped. And so it could become difficult to remove it from the gingiva, and with all the consequences that we know. The beauty in 2D. In 2D, this is a very beautiful result. More than 25 years working, this implant. It seems perfect, but it is a very old treatment. I didn't manage the soft tissue. I didn't use any dermal matrix or any connective tissue or any bone graft to correct the vestibular minus. And this is the result. Yeah, it is working since 25 years. It is a success. Logically, it's a nice tooth. It is a bad, not nice tissue. So it is not a good result. It is a success, but from an aesthetic and a functional point of view, it's not a success in my opinion. A new case, another patient. This is a lady who was tired about his bridge. She wasn't able to use the floss to floss around this teeth because she wasn't able to insert the floss from the side. And she wants absolutely 4 separate teeth. So I start changing the bridge, a provisional bridge for starting. Then I place 2 implants, one on the premolar and one in the molar region. And on the premolar region, what I did, I used a dermal matrix. This lady doesn't want to harvest some connective tissues. So dermal matrix, immediate implant, immediate provisionalization. On the molar, just an implant without a provisional restoration. And this gives some differences during the healing. Why? At the end of the surgery, you can see in the X-ray, sorry, but the laser is very slow to move. You can see transcrestal sinus elevation with the scan method, the implant with immediate restoration, the suture at the end of the surgery, 10 days later, and 10 days later at the suture removal. You can already see that here there is a lot of tissues, and here there is already a little minus. 6 months later, on the premolar side, the tissue were well maintained. You have a nice shape of the oval of the gingiva reached with the use of correct provisional restoration. So you have the root bump, you have the papilla, correct papilla, nice papilla. But in the molar region, what we see? We see a very, very important minus. These are the final restoration at 1 year from the surgery. And you can see where I use immediate provisionalization with the dermal matrix is an absolutely natural tooth. I believe that it is impossible to distinguish from a natural to an implant-supported tooth for this premolar. This is the natural tooth, and this is the implant without immediate provisionalization, without dermal matrix inside the tissue. It is not worse, but I can always see this little minus. It is a molar, nobody can see it, but in a region like the first premolar, a result like that, it would be a little tragedy. And this is the X-ray at 1 year, and you can see everything is working very well. Another case, the right central incisor had a trauma many years before, and now it is time to remove it, to extract the tooth. Or you can see from the X-ray, its mobility was big, and the patient was afraid to lose the tooth just during normal chewing. If we analyze the case, we can see that the tissue are well represented. There is a lot of keratinized mucosa. There is nice papilla, is well represented. The parabola is very nice. The parabola, it is a little bit rounded, and the adjacent tooth, it has another shape. So when we change the tooth, what I want symmetry. And if I want a symmetry, I have to ask to my technician, that is Mr. Giancarlo Cozzolino from Naples. I ask him to is as similar as possible with this one, because I want to copy also the parabola design. In this picture, it's possible to see that there is a nice root bump here, but it misses all the plate in the apical region because there is not the root. So I start for an immediate implant, an immediate post-extractive implant with immediate provisionalization. The gingiva was very, very nice, so I decided to don't harvest anything from the palate and to use a mucogain, a dermal matrix. I place some bone into the gap between the implant and the socket, and the bone, as you know, it is placed up to the free gingival margin, as you can see in this picture. You can see a little piece of dermal matrix, the bone, and the healing screw that I placed during the bone insertion. After 14 days, there is a little bump, the implant, and this is the result at 6 months. The parabola is very nice, the papilla is preserved absolutely, and now we are ready for the definitive restoration. And how you can see, Giancarlo did a very nice work together with me. I give him the possibility to have a transmucosal path identical to the contralateral tooth, and at this image, I believe it is impossible to distinguish between a natural to an implant-supported restoration. The papilla is very nice. The parabola is absolutely symmetric to the other incisor, and I believe that the patient would be very, very happy. What you see in the right X-ray, you can see that it seems that all the bone that I have placed is disappeared. And this is an image that we sometimes can note. And Benich, I don't remember in what year, in 2011, published this article in which he wrote that 1/4 of the cases controlled after 6 years lose the buccal bone. So now me, Giuliano, Chico D'Amato, and other friends are doing research. We are looking at our patient treated in the same way with the post-extractive immediate implant and immediate provisionalization. And we are looking, try to look of what is happened to our buccal bone. Because in a lot of images, we say the same thing. It's time to talk about the provisional restoration now. The provisional restoration in normal prosthesis, in traditional prosthesis, had a lot of role. In the implant prosthesis, his main role is to bring the transmucosal path to maturation. So with the provisional restoration, we sculpture the soft tissue. We create a transmucosal path in the way we want. And to do this, we need a provisional with particular characteristics. Absolutely screwed, because during the surgery, I don't want to use any cement. And if I have to remove the provisional restoration, I don't want to use an hammer to remove it from the mouth. I just want to unscrew it. So absolutely a screw restoration, and it is important that the implant system that you use has some provisional abutment like this, that you can use as you want. You can shape it with a bar, and you can adapt to the teeth you are treating. And so you can build a provisional restoration in a well manner. How are the provisional that we use? Are normal procedure, of this provisional be the same shape of the definitive crown that I will use, because it's not a provisional to rely on the natural tooth. The shape must be already the correct one. Then I need this device to place it in a nice orientation, in the right orientation. And I need a mask like this, a guide. I put inside the mask the provisional restoration, and the mask as a stop on the teeth of the patient, and I'm able to put it in the right position without any rotation or deviation, because I don't have the natural tooth that guide me during its insertion. An example, some implant placed into the post-immediate socket. I rely on the provisional restoration. As you can see, the resin has not a good shape. That after I put more resin and I shape it and polish and finish it. At the end, I have a provisional restoration like this, and you can see the provisional just screwed in the mouth of the patient. I don't have any compression. I don't give compression to the tissue. So I give the tissue the possibility to heal without any pressure. This is the X-ray. This is the image at 14 days. Another type, I can use the provisional restoration with, I call them two wings. Two wings that give a stop on the adjacent teeth. And I have a hole, you can see in this side of the image. In this hole, I'm able to see if the provisional restoration is seated in a correct way. The implant just inserted, the provisional abutment just modified, and the provisional restoration as screwed. Take in mind, remember that the provisional restoration optimizes the tissues. It does not create them. The result arises from a correct surgical planning and a logical execution. We need the 3D implant insertion in the correct way. We need to place a connective tissue graft, and we have to place some bone into the gap between the implant and the buccal bone side. If we do all these things, our words will become nice. If we don't do all these things, probably the result sometimes could be nice, sometimes could be not. But if we want a nice routine of our work, we have to do this every time, in my opinion. Almost 20 years ago, we used implant restoration like this, with a convex profile. Since many years now, more or less 20 years, I have changed my work and I use concave abutment. I want to leave more space for the soft tissue, because in this space I create trophy for the tissue and the tissue doesn't react with a resection. If I push the tissue, like in this draw, what would happen? I create a pressure, the pressure creates an ischemia, and most of the time the tissue answers with a recession. So I have a failure. At 1 year from the surgery, my tooth will be longer than in the first time. But it's not because it is an implant restoration. It is because it is wrong, the design of the abutment. So now I never use, or I almost never use this profile. In the most of my cases, I use a with a correct design up to the free gingival margin. In this side is this point, it will be the free gingival margin, and I want that my crown exit in this point for the soft tissue. It is a lot of time that Giuliano and me do this procedure, and in 2009 we already published a paper in which we control 33 implant placed in this way. Sorry, I forget to change the written, it is in Italian, I'm sorry. But with the 33 implant placed with this method, we had a very, very, very nice result at 15 months of control. We have a very little recession for the parabola from minus 0.5 to plus 1. Plus 1, it means that the parabola comes down. And we had a medium recession for the mesial and distal papilla of minus 0.21, 0.021. So I believe is absolutely a stable result. And is not our deserve, the deserve is of the methods. We always use screwed crown like this. Or better, we try to use always screwed crown. To use this crown, avoid the use of the cement and the risk to leave some cement above the sulcus. And the time that we use cemented crown, we want to use abutment like this one, with the finish line placed just below the sulcus or at the level of the sulcus, not too much inside because we don't want to have trouble in removing the cement. So take in mind, don't use components that are placed inside the sulcus, inside the gingiva, because it is almost impossible to remove the cement all around the abutment. And if we leave the cement inside the sulcus, it can be the points of beginning of an inflammation and consequently of periimplantitis. Another thing that we like is to use implant system that can allow us to have a platform switch like you can see here. And with this implant, we are very happy because we have a platform switch and a little ditch all around the collar part of the implant. And I am very, very confident with this design and I like it a lot. And the bone is very stable if you do anything in the right way using this implant, and you can see in this picture. There are a lot of things that make platform switch a nice technique, and is better used during post-extractive immediate implant placed inside into the socket. If you use this technique with this method, we will have very, very, very nice result during over the time. The trick is that you move away the gap from the abutment to the implant, you move away this gap from the bone. And moving away this gap, we will control in a very, very well manner the inflammation, the inflamed tissue around the implant, and so we reduce the tissue reaction and the bone recession. So every time use a platform switch, in my opinion, is a very nice technique. But how we make a provisional crown? How we make it? We have a tooth to be extracted. This is the crown with the little two wings. The emergence profile is already the definitive one. I don't have to change the side of the provisional, but from this side, I start with my concavity. The two wings allow me to insert the provisional in the correct position. The implant, the abutment, I modify it remove specks of resin. This is how it appears as removed. I add some resin, and then I have to finish and polish it accurately. We don't need rough surface inside the sulcus. It is mandatory a very, very smooth surface. This is the provisional just screwed. You can see that there is no pressure on the tissue, there is no ischemia. 1 year later. This is the impression. I have just screwed the abutment. You can see that it doesn't give any pressure to the tissue. It is the exact replica of the provisional restoration. And then we will see how to do it. And this is the final result. I believe that it is impossible to distinguish the tooth on the implant from the crown on the natural tooth. They are almost the same, with the same design of the papilla. You can see the mesial papilla is the same. This is the natural, and this is the implant. We have a very nice parabola and a very, very natural papilla. How can I transmit this profile to my technician? I can use the INS method with a conventional impression. I connect the provisional restoration to the analog. I insert it in some imprint material, and you can see here the difference between a conventional transfer to the design that I have with a provisional crown. I put some resin, and what I get is a custom-made transfer. The transfer-made transfer remaining save the imprint, and then the technician has all the information in this cast to replicate my transmucosal path. And this is the final restoration. You can see it has the same shape of the natural tooth, the same design, obviously inside the sulcus of the mine provisional. And the results are very stable over time. Today I do this in a digital way. This is the deciduous canine. I have to remove it and to change the smile of this patient. It undergo ortho treatment. At the end of the ortho, I could place the implant. There is a permanent canine that is impacted, as you can see in this X-ray. I place the implant. I have a little space in which to place the implant. This is the immediate restoration, always the same thing. This is the X-ray. 6 months later, the buccal plate is well maintained, as you can see in this picture. The papilla is nice. The transmucosal tissue are very healthy. And now I can do a digital impression, as you can see in this film, without the scan abutment, with the scan abutment placed into the mouth. And this is what we obtain. It is a digital cast, I can call it in this way, but the better thing is that my canine has the identical transmucosal path of the provisional restoration, and so I don't have any recession. The tissue are absolutely stable. The papilla is very, very nice, is well represented, and I believe that it is impossible to understand that under this tooth is there an implant. It seems a normal and natural tooth. And this is the new smile of the patient. I believe she can be happy. I can do this technique only in the frontal area or also in the posterior. We can do everything you want. As I already told in the first half of my lecture, we can do everything. We have we can place an immediate implant in the premolar region with a contemporary regenerative technique, as you can see in this case. You can see the gap, you have seen the fenestration. This is autologous bone, some chips of autologous bone. Then we place some heterologous. And we do in contemporary an immediate restoration, immediate implantation, immediate regeneration. Everything immediate. This is the result at 6 months. And this is the final restoration, and I believe that it is absolutely natural. Can I do this also for multiple elements? In the literature, you can find that it's better to avoid simultaneous post-extractive implant in the same time when they are adjacent. In my mind, is not true. Why? Because if we take in mind to maintain a correct distance between two implants, to avoid the crater that is formed around the implant are not able to reach between them, if I'm able to maintain this distance between the implant, the result will be nice. The bone will remain stable. I can use a device like this. I've already showed you last time. This bar was invented by me, so I believe that it is beautiful like a song for me. I like it a lot logically. I just place the bar against the root of the adjacent tooth. I choose the bar. The size of the bar is depending on the implant diameter that I want to use. And as you can see, this is the first drill. If I use the bar on the first drill correct, the implant will stay at 1.5 millimeters from the adjacent tooth. So I respect the bone peak, and if I respect the bone peak, the result will be nice. I can use it also between two implants of the same diameter, like in this draw in this picture. And I can have 3 millimeters of space between this implant, 3 millimeters of space between this implant, just using the bar without any measurement. And then I can use the mesial space as I want, because I don't have any risk of to place the implant too close between them. More, I have to place an implant in this position. I choose the bar of the right size. I do just one incision, a crestal incision without vertical incision, a very, very minimal approach. And just using the bar, as you can see, I don't have to see what I do because I trust into the bar, and the implant will be in the right position. Also, if I don't see what I'm doing, I trust the bar. Another case, I have the provisional restoration. I put the bar, I put my first drill, and I can see that the first drill, it is in the middle of the tooth. What it means? It means that the implant, it will be in the right position. So I can place the implant in the lateral side without any complication, without the risk to have the wrong position, without the risk to place the implant not in axis with the tooth. And you can see it is very easy. Another case, this lady came to my office many years ago. She told me my premolar are moving, and she was right. As you can see, with 2 fingers, I removed the tooth, and these are, I removed the crown, sorry, and these are the tooth with a big decay, almost destroyed. So what I did, I extracted the teeth, I placed the 2 implants. These are the provisional abutment, and these are the provisional crown just screwed. There is no pressure on the tissue. Take in mind, no pressure. Take in mind the position of the tissue. The tissue will remain very stable, and you can see here the green line. I'm fighting with the laser, as you can see. Here is the green line, and this is the green line that I did with a pencil, because from that line I started with the concavity. So the tissue remained very stable over time. But the best picture is this one. You can see the parabola is wonderful in my opinion, and wonderful is also the papilla between the two implants. It has the same shape of the papilla that we have between two natural tooth, and is not deserve mine deserve. The deserve is of the technique, because I always do the same thing. You can see how the buccal bone plate is well maintained. Here in the back area there are two old implants, and you can see without doing this how the crest is shrinking. And this is the final result at 1 year. Very, very, very nice soft tissues and very nice porcelain crown. They are made in, every time from Giancarlo Cozzolino. And you can see the stability of the tissue, but better more, you can see the stability at 5 years. This is 5 years later. The tissue are very stable. The root bump is well preserved. And I believe that it is impossible to say that under this crown there are two implants. We can do the same in a molar region, yes. There was a fracture of the root, so I separated the two roots to maintain intact the septum, and then I placed the implant inside the septum. This is the implant, this is the bone up to the pharyngeal margin. This is the provisional restoration with the concave profile. Just screwed, you can see that during the extraction of the tooth, I lacerate the soft tissue. And this is the X-ray at the end of the surgical treatment. 10 days later, 1 month, the laceration is healing. 6 months, we are ready for the definitive crown. The transmucosal path is wonderful in my opinion. We can see some residual chips of heterologous bone. According to Araujo, it is absolutely normal. It is not a method. And this is the final X-ray and the final restoration at 1 year. The tissue are absolutely stable. The profile of the crown and of the soft tissue is identical at the profile of the natural tooth, so we can say to have done a very beautiful work. But we love the risk, so we have to extract this molar. We studied the CBCT, and we can see that there is a septum of 5.7 millimeters of weight. So what we did, we extracted the tooth, and we did the sinus membrane elevation with the scan method. This is the septum, is a very, very nice septum, very big. This is the implant just placed. There is the bone up to the pharyngeal margin, I always told to you. The provisional restoration with the concave profile, the provisional restoration just screwed, the X-ray and the CBCT at the end of the surgical. 6 months later, we are ready for the impression, digital impression. And this is the final X-ray and the final restoration. And how you can see, also in this case, with the sinus elevation, with the complication, if we want, the result are well preserved, both mesial and distal. The bone around the implant in the sinus is very nice, but most important for us, because the patient doesn't look at the X-ray, the patient look at this, the parabola and the soft tissue, the papilla around the tooth are very nice, and the patient is very happy. Concluding, definitive abutment. It is a very old case. At the time, I was used to cement the crown. You can see the profile is juxta gingiva, the crown at 1 year, the crown at 3 years. The tissue are very stable. I like to use this motto, root bump preservation, because I preserve the root bump from the shrinkage doing this technique. The beginning, 3 years later, the beginning, 10 years later. I believe that this patient could be very happy about this result. As you can see, their teeth are moved, but my implant is stable, the soft tissue are very stable, and the result is stable over time. And this is what I want to see, or what I would like to see every time I work. I conclude with an article written by me and Giuliano and other 2 friends. We have a look at a lot of implant placed by us at 10 years with this technique, and the result was very stable. We have 98% of success, very few bleeding on probing, and the results are very, very stable. And so I thank you for your attention, and I thank you also Giuliano. Giuliano Garlini is my friend with which I work since more than 20 years. He's like a brother for me. And so thank you very much, and have a good day to you all.